So basically, I'm starting with a case. This is something I faced in reality. Both the parents are pediatricians, no maternal risk factors throughout antenatal pregnancy. Emergency LSCS was done for so-called fetal distress in a nursing home. Baby didn't cry after the birth. So delivery was attended by a pediatrician who gave CPR with ambu bag, and then baby was revived, and then transferred the patient to us. Now at 2 hours of the life, baby has the symptoms of HI stage 1 according to Sarnes staging, and then the baby develops seizures at 5 hours of the life. So now the pediatrician mother as well as father is asking, what do we do further? How do we help? So kind of, what would you do? Anyone? Okay. Question is, can we do something more than what we have done all these years traditionally, conventionally? This is the outline of the talk basically. We want to go through background, pathogenesis, most current treatment modalities available, benefits of hypothermia, role for the cooling, what is the evidence, why do we need to change our practice from what we are doing, and then we will talk about the protocols for that. We all know birth asphyxia is still a number 1 cause of neonatal morbidity and mortality in the world. And 50 to 60% of the patients with the severe asphyxia, they develop multi-organ dysfunction. But out of all, what we are worried the most is basically the CNS involvement. Almost 70% of the patients with the severe HI, they have CNS involvement, and out of them, more than 25% survivors have long-term neurodevelopmental impairment, which is something really bothers us as a pediatrician as well as neonatologist. Now what happens, we all know there is a so-called diving reflex in the body. For any reason, if there is an interruption of the placental blood flow, that leads to decompensated circulatory response, which leads to systemic hypotension and ischemia. So body has a diving reflex. The body will divert the blood to the most vital organs of the body, and those are basically brain, heart and adrenal glands. So there will be redistribution of the cardiac output by stealing the blood from the non-vital organs, which is basically our kidney, gut and skin. But then we do CPR at the time of the birth, and there will be establishment of the circulation, which will lead to the reperfusion injury. These are the factors, maternal, uteroplacental as well as fetal, which basically contributes to antepartum and intrapartum asphyxia. We always talk about the events, from the time the baby is born. We never, or probably we don't give that much emphasis on intrapartum and antepartum factors, but we need to. Many times gynecologists, obstetrician will ask innocently, what happened? कुछ भी risk factor नहीं था तो फिर अब क्या हुआ? And these are and then they try to kind of blame us for our incompetency or whatsoever. So we all need to be kind of aware about it, and always have to have a habit at the spinal level to cross check what are the risk factors, and all of them can contribute to this unexplained birth asphyxia at the time of the delivery. Now what happens in HI at the time of this hypoxia, because of the lack of the oxygen to the blood, that leads to lack of the oxygen and the glucose delivery, leading to anaerobic metabolism, will lead to the primary neuronal loss at the time of the asphyxia, at the time of the birth. Then there is a period of around 5 or 6 hours, which we call as a latent period, where some kind of the autocompensation in the body starts, and then the real reperfusion injury starts with the kind of lot of inflammatory changes in the body, including releases of the excitotoxicity amino acid in the brain, particularly glutamate. Now, with that, there is a chain of the biochemical reactions setting in the neuronal cells, which lead to the secondary damage to the brain and secondary neuronal loss. So there is an initial insult. We can't do anything about the birth asphyxia. We cannot undo the events. But always the question comes, can we do something about preventing secondary problems, secondary neuronal damage? And can we, if we cannot undo or prevent the primary insult, can we minimize secondary damage or not? So this is a window of the opportunity of almost first few hours of the life where we can offer something and may be able to contribute to minimize brain injury. This has been very well studied when people did the research by using MR spectroscopy, and they have shown very well primary and secondary energy failure on spectroscopy. What are the benefits of hypothermia? If we cool the brain temperature by 2 to 3 degrees, it has a multiple advantages, very well shown in the animal models, and not recently, long ago. but we have started paying attention to it now recently in last decade. It reduces oxidative stress, it reduces apoptosis, it reduces cerebral metabolic rate, it increases superoxide dismutase activity, it attenuates release of the excitatory amino acids like glutamate and dopamine. It also lowers production of toxic nitric oxide and free radicals, and by doing all this, it reduces neuronal loss on histopathological examination in post-mortem examination. And these are all the mechanisms for the primary and secondary brain damage secondary to HI. Now I always believe, when I'm doing something, I'm knowing something, I'm quite comfortable with my one method of, practicing it. All this is like what Samir said, why do I change to something else? So having some kind of the non-obedient nature, I need to know why. And because of that, we all need to do that. We need to check the evidence time to time, and accordingly we have to learn to adapt and kind of, readapt our practices, keep auditing our practices. So when I talk about something, before doing that, probably I need to convince you what is the available evidence about it. Okay. Sorry? So, in Lancet in 2005, one published study which was kind of noticed by the whole world, Gluckman presented, he did RCT in 234 term infants with moderate to severe HI with abnormal EEG, randomized to either conventional care or cooling to 34 to 35 degree within 6 hours of the birth. He used a kind of, kept a special device to cool the selectively brain. But when you cool the brain, it is not possible to disconnect the rest of the body with the brain. So there was some degree of the mild hypothermia with the rest of the body also. Alright, I'm always poor in kind of, reading out this chart, so I'm going to explain it in a very simpler way, the way I understand. So here this is a cool group and this is a control group who received conventional treatment. Now we look, the people who died or had a severe disability at the age of 18 months, the percentage of the people in the cooling group are much lesser compared to the conventional group. The patients who died were more or less same in both the groups, but patients who had a less neuromotor disability were bigger in the cooling, they were smaller in the cooling group compared to control group, but that was particularly, they did subgroup analysis into that, and this difference was coming out because they cooled patients with the severe HI. But if you look at the Bellis Mental Developmental Index scale, it was less than 70. So percentage of patients with the neurodevelopmental impairment were lesser in the cooling group compared to control group. But none of these values were statistically significant. So this paper actually told us that there is some potential role, but that requires statistical significance to kind of, be accepted as a generalized standard of the care. But with this and after this, almost 8 RCTs were done in the time span of 2000 to 2010, and then someone actually published meta-analysis of that in Cochrane. Out of it, 3 were large actually series, same inclusion criteria, and what they came up with. The conclusion of the Cochrane review was that it is beneficial to the term neonates with HI. It reduces mortality without increasing major disability among the survivors, and benefits of cooling on survival and neurodevelopmental outcomes were outweighing the short-term side effects. Because we all are scared, because the first thing I learned as a resident in my housemanship in my college was not to allow baby to be hypothermic. So this was completely opposite of the first lesson we learned as a pediatrician in our residency. But by the end of 2008, I think most of the good centers of the world were convinced that cooling is beneficial. In fact, I think Vinay is here. In SickKids, when Vinay was a fellow, the SickKids was involved as a part of the trial, and then at the end of the trial, the results were so obvious that they didn't even complete the study, and it becomes converted into the kind of standard of the care. Another landmark trial we all need to know, published in New England Journal of Medicine, TOBI group, multi-center randomized trial. Again, whole body cooling at 33.5 degrees centigrade for 72 hours. They measured outcomes in terms of Bellis scale of infant development 2, in terms of motor developmental index, psychomotor developmental index, and gross motor functional classification system, and visual loss. So again, when we try to read this table, if we look here, This is the cool group and this is the non-cool group. So if you like less than 70, mental developmental index score less than 70 shows severe neurological impairment, and here the number of the patients who were cool, the incidence is much less compared to the babies who were not cool, and the incidence of cerebral palsy was much more lesser in the cool group compared to non-cool group, with very significant statistically. And they also looked at the kind of the adverse events between the two groups, but they were more or less same in both the groups. So, Toby didn't show significant reduction in the combined rates of death and severe disability with the cooling as compared to no cooling. It showed significant improvement in several secondary neurological outcomes among the survivors. And adverse events were minor, and they were present in both the groups, which suggested that it was primarily secondary to birth asphyxia and it was not essentially secondary to hypothermia. So people who were scared, they actually felt a little better with the this results. But again, we all were worried, and we know and we will discuss about all these complications secondary to hypothermia. So there was also a good question whether what if it only had cooling, because in that case we don't need to bring down the whole body temperature to a very low degree, 33.5 degree, and in which case can we minimize secondary side effects of cooling in an immediate neonatal period. So this question was also answered in a short series, and they could not find any kind of the difference between immediate adverse events secondary to cooling. So both were same. So then it like whether you have you go for selective head cooling versus whole body cooling, doesn't matter. The outcomes are going to be same. The same people who did these studies earlier in 2008, and out of those three big trials, they actually those subjects of those three studies actually grew to the kind of 18 months. So they did neurodevelopmental assessment of those children, and then they presented their results. And again, to make it very simpler, don't ask me what is relative risk, but the important part to know is if your relative risk is less than 1, that means risk in exposed is much more lesser than risk in non-exposed. So when we kind of review this, if your relative risk is 0.8 for the outcome like death or severe disability, that means the cooling group is beneficial. Survival with the normal outcome is actually bigger in the non-cool group. Mortality is much more lesser in the group which were cooled. Severe disability among the survivors, cerebral palsy, severe neuromotor delay, developmental delay, blindness and deafness, all these incidences are much more lesser in the cool group compared to non-cool group. So I think from 2010, the therapeutic cooling has become the standard of the care in all the developed countries. Are you all with me and in agreement so far? Okay. So then the question comes, yes, if we are convinced, how do we cool the baby? So the protocol is we should preferably start cooling at least before 6 hours of the birth for the eligible patients. But if not, at least before 12 hours, though the benefits may not be as good as if we cool the babies earlier than 6 hours of life, but there are still benefits. But after 12 hours, probably there are no obvious benefits, so then those patients should not be cooled. Inclusion criteria, standard stage 2 and 3, 3 or more out of 6 categories of the staging, plus evidence of intrapartum hypoxia, which is basically 2 out of 3, Apgar score less than 5 at 10 minutes of the life, need for the mechanical ventilation or no return of the spontaneous respiration at 10 minutes of the life, and cord blood gas or blood gas within 1 hour of the birth with the pH less than 7 or best deficit more than 16 millimole per liter is basically, these are the babies, they are meeting criteria to be cooled. Yes, so far in all those trials, they cooled only term babies or near-term babies. So they suggested, when they put it as a standard of the care, to cool only those babies who are less than 35 weeks. But by the time I left my center, the comfort level was so high that we started cooling even babies as small as 32 weeks. But that has to still come into the publication in near future. And not only that, people started questioning why for 3 days, why not for 4 days, why for 5 days. So I think there are some centers which are still studying benefits of the hypothermia for 5 days, but that also need to come into publication in the future. Exclusion criteria. These are relative criteria. These are not absolute criteria. Less than 35 weeks, patients less than 2 kilo, patients with evidence of active significant hemorrhage. What do you mean by active significant hemorrhage? Any bleeding which can make baby to die. So basically that is your either pulmonary hemorrhage, your large subgaleal hemorrhage, your big GI hemorrhage. Just simple pathogenesis on the skin is not going to stop you cooling the baby. Now this is something they have written because abroad even for the normal babies they manage and monitor rectal temperature. So people question how do we cool them, but you can put esophageal probe, but imperforate anus is not an exclusion criteria. Requirement, you need hypothermia blanket. I know what question is going to come after that. I will answer it in advance. Rectal probe or esophageal temperature probe is must. There is no alternative for that. Skin temperature probe. We will talk about the monitoring, but more importantly expertise. Because moment you cool the baby, you lose your capacity to monitor the patient clinically. So you need to say few babies are being cooled, because being cooled and being in a low cardiac output is not safe. And we all know HI babies are prone to develop myocardial depression leading to low cardiac output. So still you need that kind of little experience to know that this is not a low cardiac output stress, this is a pure hypothermic effect and something like that. Now, how do you provide? So basically, it should be started before 6 hours of life preferably, but once you identify, you should start cooling baby passively as soon as you identify, maybe at 1 hour of the life. And that means do not turn on your warmers, and if you have ice packs, please use it during the transport. Once you get the baby in the tertiary care unit, you put rectal probe and aim to maintain rectal temperature 34 degree plus or minus 0.5 degree for 72 hours. By active cooling, one can go for either head or whole body cooling, and once you cool the baby, no problem, but you have to be extra careful when you start rewarming the baby. Rewarming, the rate of cooling can be as fast as half an hour, but rate of rewarming should be very, very slow, because whatever you have suppressed by cooling, those things can come up, and patient who is not seizing can start seizing while you start rewarming the baby. So you have to be there at bedside when you rewarm the baby. Don't allow temperature to rise more than 0.5 degree. And if you see some kind of the problem like seizure activity, you again cool the baby for another 24-48 hours, and then when you restart rewarming the baby, become even slower. So maybe you allow temperature to increase by 0.5 degree every second hourly or something like that. Monitoring. So as we discussed, we lose our capacity to judge the patient clinically. So these patients require extra blood work. Now it is very, very even like we keep on stabbing patients we take only arterial collections of samples. Despite that, once I pull the baby, my capacity to stab an artery is extremely low, because arteries go into the vasoconstriction, so you don't get arterial blood that often, and this patient requires frequent blood monitoring for multiple things. So you need to put UAC, UVC or central line and arterial line before you start cooling the baby, not after you cool the baby. Secure your lines is a kind of the dictum. Threshold to put UVC and UAC in these babies are extremely low. It is not necessary to keep the patient on the ventilator throughout the cooling period. You may extubate them while you are cooling the patient, but they do shiver on cooling blankets or with the ice you keep around them. So you need to keep them little kind of discomfort free while you cool these babies. Anyway for HI, the incidence of SIH which is extremely high, so we need to monitor fluid very kind of closely. Nutrition, so far we don't have a clear answer when we should start feeding actually the babies with the severe birth asphyxia. That was one of my thesis I kind of wrote in Canadian Ethics Committee. Still we don't have answers. So normally we all keep them NPO for 3 days till we get a clear guideline. But in that case, we need to start some IV nutrition from the time of the birth. They do require sedation and analgesia to be kind of discomfort free. the hypothermia decreases your kind of drug clearance. So ideally we are supposed to monitor drugs like drug levels like phenobarbital and narcotics if we have facility. We do need to kind of do continuous EG monitoring at least with 3 leads. Now I know it's not available in most of the centers of India, but that's the ideal recommendation. That also gives us a kind of a background EG information, and it is one of the, it can be used as a prognosticating marker also in terms of the HI recovery. So if you see normalizing background activity within 3 days of cooling, it is reassuring for a good neurological outcome later, but I think it is yet to come in our market. Probably it will take another 20 years to make it kind of cost effective. And we need to see multi-organ dysfunction monitoring. So these patients require daily, at least daily blood work of LFTs, RFTs, INR. Cooling also, the INR is inversely proportionate to the degree of the cooling. So it is very common to see INR of 2.8, 3, 3.5 once the babies are being cooled. And that was another my research question in Canadian University. What should be the transfusion threshold in this baby? Should we simply treat a number because they don't bleed? If they don't bleed, why do we end up giving? And if they start bleeding, then your treatment is you just rewarm them. Once you rewarm, your bleeding will be taken care of. So this question is still not answered, yet to come in the publication. So these are kind of equipments. Basically rectal probe we need. This is a cooling machine for the whole body cooling. But what we need is, we need to wash the baby. We have to be at bedside, and baby needs basically arterial line insertion. Future directions, some of the experimental medicines still in the research lab, not been tried in the humans yet. Potential role, waiting for more publication to come. So as of now, I think only recommendation and standard of the cooling is recommendation is for the therapeutic cooling for HI. Rest of the drugs are still on experimental stage. So I hope, wish and guess that we all are convinced now that since we know long-term outcomes are poor, we need to cool the baby. It has become the standard of the care globally. And benefits of the cooling are far more better than short-term adverse events secondary to cooling, which are easily manageable as far as we are there to see the patient. Then why not to cool the baby? I know you all want to know the question. The question is basically, is the cooling blanket available, and if not, then how to cool the babies? I think that's going to be the question. So before I answer, I think I asked Ashish Bhai, who has kind of has the largest number of the neonatal practice in whole state in corporate sector. So, sir, आप क्या करते हैं? You have cooling blankets. And how expensive are they? They want to know actually.